Hello, I'm Dr. Diana Morse, and I'd like to welcome you this afternoon on behalf of the School of Nursing and Dean May Weichel to the Rozella Schlotfeldt Lecture Series. Dean Weichel isn't here because she's somewhere else on campus giving awards away today at an honors ceremony. She may join us later. Before our guest speaker is presented by Dr. Lynn Lotus, Director of the BSN program, I'd like to just share a couple comments about Dean Rozella Schlotfeldt, for whom this lecture is named. And Dr. Schlotfeldt was one of those legendary nursing leaders who became a living legend of the American Academy of Nursing. And I was once told by Joyce Fitzpatrick that the way you become a living legend is when someone says your first name in a room of nurses, everyone knows who you are. So Rozella was a living legend. And it's very appropriate that the lecture series is focusing in on global health issues, because Dr. Schlotfeldt was a member of Sigma Theta Tau International and chartered the chapter Alpha Mu here at Francis Payne Bolton School of Nursing when she was dean. She also was an active member throughout her career of the International Council of Nurses. She was a prolific writer and one of the most creative educators that we've had in nursing, and in fact was the mother of what has become the clinical doctorate program, what started out as the ND. And I used to ask Rozella, I was fortunate enough to know her in her retirement when she was still actively writing, actively presenting, and running around stirring up trouble because she liked to get discussions going. And she would come to sessions like this or classes, and some of the juniors out there can appreciate that, challenge the students to think about their philosophy of nursing and to think about what that meant in terms of their careers and to begin to think about becoming scientists. She very early on, as dean of the School of Nursing, made the mission of the school not only education but research, and many of you probably don't know that the School of Nursing we're in now, though it's getting old now, was quite avant-garde at the time, and some of those funny rooms that we use in the school now that have two-way mirrors, etc., that building was actually built so that people could do sensory deprivation research in the School of Nursing because of the interest of the faculty. Her papers are still classics, and I'm sure Rozella would have a fun time here and be the first one to engage Dr. Nunez in some discussion and dialogue upon the end of her presentation. So, welcome. I know this will be a good experience, and I'm going to ask Dr. Lotus to come forward now.
Hello, welcome. Dean Weichel is actually at the award ceremony for the non-graduating students right now. We had to draw straws to see who was going to be where, since everything's scheduled at the same time. So she is there and will be joining us later, hopefully. It's my very great pleasure this morning to introduce Dr. Maxine Nunez. Dr. Nunez teaches community health and leadership in nursing at the University of the Virgin Islands, and also serves as Research and Pilot Studies Core Director at the university. She received her BSN from Loyola University in Chicago, her MSN from Boston University, and her Doctor of Public Health from Johns Hopkins University in Baltimore. Previously, she's held positions as faculty at the University of Maryland, chairperson of the Division of Nursing at the University of the Virgin Islands, and Dean of Instruction and Academic Affairs at the university. She's also served as consultant to the World Health Organization and the Pan American Health Organization on health issues of the Caribbean, and has written extensively in this area. Her research is focused on issues related to living with type 2 diabetes, and she's currently principal investigator for an NIMH HD grant, Factors and Life Experiences Affecting Self-Management Among a Population of Type 2 Diabetic patients in the United States Virgin Islands. She's been the recipient of many awards, including a National Science Foundation Scholarship, a Public Welfare Scholarship, and a Nurse Scientist Fellowship. She's a reviewer for the journals Ethnicity and Disease and the Journal of Excellence in College Teaching. She's a member of Sigma Theta Tau and a member of the Association of Community Health Nursing Educators, where she served as a board member and a member of the executive committee. She's also part of an educator's dynasty coming from the Virgin Islands. She's the daughter of the late Mrs. Teresita Nunez, a well-known Virgin Islands educator, and her own daughter, Marcella Nunez Smith, is assistant professor of medicine at Yale University and assistant director of the Robert Wood Johnson Clinical Scholars Program there. Please join me in welcoming Dr. Nunez.
Good afternoon, everyone. It's a pleasure to be here and to be with you. I'd like to say thank you very much to the Dean and to Dr. Lotus for inviting me to be here. I was really shocked when she posed this to me when she came to St. Thomas. I think it was in November last year. We were having lunch, and she says, "Oh, I'd like you to do X, Y, and Z." And I paused, and I didn't give a response, and then she came back at me, and I said, this is really an honor and a wonderful opportunity for me to come to Case Western Reserve and meet you and tell you a little bit about the part of the world that I am from. So really, it's my pleasure to be here. Thank you very, very much. So we will talk today about health determinants and inequities in the Caribbean context. And I would like us to have a conversation, so I will work through my slides in a timely fashion so that we can have commentary and we can have discussions at the end. But I will be remiss if I don't also recognize a couple people in the audience that I know. I'd like to say good morning to Dr. Patricia McDonald, who worked with me at the University of the Virgin Islands about 2 years ago and taught psychiatric nursing. And I'd also like to tell you about two very special people in this class to me. They are Bahara Kamani and Ashley Quick, sitting up here in the front. By my instructions, I tell them they had to come forward. As most of you may know, they were in St. Thomas at the University of the Virgin Islands for the community health experience last fall, and we got to know each other very well. And I'm delighted to see them again. So, just for geographic orientation, many of you know where the Caribbean is probably, because it is such a well-visited spot for tourism. But I would like to tell you more about the region that we refer to as the Greater Caribbean. The Caribbean is more than just small islands that form an archipelago between Key West, Florida, and South America. It encompasses all land masses upon which the Caribbean Sea washes. So countries in South America like Guyana, Venezuela, Colombia, Suriname are considered also part of the Caribbean, as well as countries in Central America, Mexico, Nicaragua, Honduras, and so on. So when you put all of those peoples together, you get a population of about 250 million people, which approximates the population of the United States. So I'd like you to notice where the Virgin Islands are. It's like midway between North and South America. There are CARICOM members. I'd like to introduce to you the term CARICOM, which stands for Caribbean Community. Our focus this morning is going to be primarily in talking about English-speaking Caribbean islands and countries. And they together are part of an entity, an administrative organ that we refer to as CARICOM. CARICOM will be reappearing in my talk because it really is a mechanism through which and by which the changes that I think needs to happen in terms of closing the gap in health disparities, it is through them that I think much of the initiatives, and many of the initiatives, will take place. So some of the familiar names, the Bahamas, Barbados, Guyana, Jamaica, Trinidad, and Tobago, as well as some smaller islands, Anguilla, Antigua, BVI, and so forth. These are all CARICOM member countries. So now that you know where we are geographically, let's take you there visually to see the beauty that belongs to the islands of the Caribbean. Dominica market scene is most appropriate because Dominica is still very much agrarian, and more than any other island in the Caribbean, it contributes to its own food basket. Here is St. Lucia. Bahare followed a family from St. Lucia. They were new immigrants to the Virgin Islands. And so here is a smaller country. They don't spend very much on healthcare at this point. They're poor. I will talk to you a little bit more about that. St. John, part of the U.S. Virgin Islands, just abundantly blessed with natural beauty, but the rest of us can't complain. Tortola, part of the British Virgin Islands. Batchabar, Barbados. Barbados is one of the more progressive islands in the Caribbean by objective measures and indicators. This part of Barbados is on the Atlantic coast. That's why the water looks so furious. St. Kitts, Nevis, immigration in the 1960s depleted the population so that they have about 35,000 people there, which is about a third of what we have in the U.S. Virgin Islands, but the land mass is about the same. Virgin Gorda, also part of the British Virgin Islands. This is a very well-known scene to tourists because it's the famous bats. And Trunk Bay of St. John, noted for underwater snorkeling. So let's look at what our discussion is going to be today. We will talk about the Caribbean in 4 parts. First, we're going to look at the major health problems of the Caribbean region. And then, to understand health problems anyway, you should have some knowledge about the social environment and the economic environment in which the people live. I am from the U.S. Virgin Islands, and as you heard in the introduction, I am studying diabetes 2 in the USVI. I'm going to use my findings from this primarily to give you an enriched sense of cultural influences on how people behave in response to their chronic illness. And then to end on a positive note, we're going to move forward looking at what the next steps ought to be if we are to approach equity in the Caribbean. There are 2 objectives to be met in part 1. Identify the major health problems, primarily of the English-speaking Caribbean, and to compare these with the United States. So, it's not surprising to you, heart disease, stroke, cancer, diabetes are the main causes of death in these Caribbean islands, as is true also of the United States. But in addition to these conditions, HIV/AIDS is a major problem, and even though it is communicable, I need to mention it because the incidence of HIV/AIDS is the highest in the Caribbean, second only to sub-Sahara Africa. So when governments have to contend with that, in addition to non-communicable chronic diseases or NCCD, it's a double whammy, and so it's not to be ignored. Chronic diseases contribute to about 50% of life loss. So we're going to look at slides that show you how many years of life the human capital is depleted because people simply don't live long enough. And that's because of conditions that they have that can be treated and complications prevented. However, that's not happening. Hypertension is a major, major problem for us. It affects about half of the Caribbean people and over 40, and 20% of those people also have diabetes. These slides have been prepared by an organization in the Caribbean referred to as CARIC, the Caribbean Epidemiological Center, which is located in Trinidad and Tobago. And they are the only organization in the Caribbean that prepares epidemiological data. It is a corollary to your CDC, the Center for Disease Prevention and Promotion. The USVI collects its data and sends its data to CDC. The rest of the Caribbean that subscribes to and supports CARIC submit their data to CARIC. So we're going to look at crude mortality rates for men between the years 2000 to 2004. I just want you to see some trends that are happening. Never mind that you might not be able to read the names of the conditions. But to the very top, that orange line that peaked and rose again and is on the decline, way exceeds everything else. That is heart disease. The blue line, the bold blue line towards the bottom is HIV, and you can see that it dropped off in 2002 to 2003 very strongly, and now it's leveling off. Cancer is the only one of the conditions slightly on the uprise. Diabetes is the dotted purplish line. Let's see how it looks for women. Take a look. Does it look any different to you? Take a look. Does it look any different? Basically, it's no difference. There is no difference between men and women when it comes to the incidence of these diseases and the mortality that applies. Now let's look at the potential years of life lost for HIV injuries and NCCD for 3 age groups. Keep your eyes on the orange bars. Just keep your eyes on the orange bars. The orange bars represent the potential years of life lost for NCCD, the non-communicable chronic diseases. The blue one in front is HIV, and the green one happens to be injuries. What's happening here? Even though HIV is pronounced in terms of potential loss of life, it is still exceeded by the orange bars. Let's look at the next slide. What's happening? 45 to 64, everything else just about disappears. So it's just about disappeared. So the only thing that you see still dominating by the time you get to age 45 to 64 is loss of life due to NCCD. Let's look at the leading causes of death in 2004. This simply takes one of the earlier slides and take the pie diagram and looks at the pie diagram and see how you can further differentiate what's happening. So for cancer, yes, there's breast cancer, there is prostate cancer, but other neoplasms really make up more of the reason for death. Heart disease, heart attacks. Heart attacks overwhelmingly is a cause of death. Other heart diseases, congestive heart failure and so on, responsible for a smaller part of the pie. Injuries, somewhat more evenly distributed among homicide, vehicular accident, and other injuries such as from job and such as job related. So what we can take away from this first introductory part of our talk is that in the Caribbean now, non-communicable chronic diseases has outtaken infectious diseases as an area of concern. Remember now that most of the Caribbean was colonized as recently as 1960 by Great Britain. So all of the countries that we're talking about, the English-speaking countries, have in common a historic past that included colonialization. And I mention that because much of the progress that has taken place post-colonialization. So 40, 50 years later, we see the absence of infectious diseases. We cannot ignore that that is significant progress. In the 1970s, infant malnutrition disappeared from the Caribbean except in Haiti. So that's important progress. A sustainability now that may be trumped only by an attack on NCCD. Excess debts, that are debts that don't need to happen, but have happened because of not approaching NCCDs, not being able to intervene yet in terms of making the difference in keeping people alive once they're diagnosed. We saw that there was no gender difference in NCCD, in the incidence and the mortality. And after age 45 to 64, it is the predominant malady. So to understand what happened, we need to talk about social factors, economic issues. So the objectives now is to interpret the gravity of health issues in relation to economic realities in this developing part of the world. What are the factors such as availability and accessibility of healthcare that affect healthcare delivery and healthcare status of the people? And what about surveillance? What's the status there? What's the infrastructure like for collecting data? The single measure, as you all know as nursing students and nursing faculty, the single most important measure of the health status of any population of people is infant mortality rate. So we need to start looking at what the infant mortality rate is for these countries in the Caribbean. The infant mortality rates have declined steadily and consistently in the Caribbean from about 56 per thousand births in the 1960s to 10.48 in the 1990s. The lowest infant mortality rate is in Cuba, which is 6 per thousand, which is actually better than in the United States. Guyana remains high, approaching 50 per thousand. Look at this slide. Just take a look. All I want you to see is the wide range of infant mortality rates in the countries in the Caribbean. To the very, very top with the highest rate, here approaching, actually it looks like it's over 60. What country do you think that is? Haiti. And down to the very bottom, I just told you what country that is, Cuba. Cuba has sustained this since before 1992. There have been shifts with other countries, but Cuba has been able to sustain its low infant mortality rate from before 1992 and still has it. I am going to point out where the Virgin Islands is. It's like the fifth bar up. We have about 9 per thousand, and right above us is Puerto Rico, approaching more like 10 per thousand. We're the only two places in the Caribbean where there's U.S. jurisdiction. So it's interesting to see we are a little bit above what you have here in the United States as your infant mortality rate. And I need to just add anecdotally here that what's happening in the Virgin Islands is a new immigration wave of people from Hispaniola. So those are Haitians and people from the Dominican Republic. And in time, that will affect the infant mortality rate if these individuals do not seek out prenatal care, which is the apparent reality now, is that they are least likely to come for prenatal care, even if that prenatal care is free. The red line represents the average, the mean infant mortality rate for these 35 countries and territories. And I think it's a remarkable slide because if you look at the number of countries above the mean and the number of countries below the mean, it is cause for hope. There are many more countries below the mean than there are countries above the mean. And that indicates to me that probably the mean is skewed by a few countries like Guyana and like Haiti that have really excessive, very, very high infant mortality rates. So, what then, again, looking at social context? The governments of the Caribbean put tremendous emphasis on education. Education is government subsidized at the primary level and at the secondary level. And they feel that education is a way to economic progress and success. I think it's a remarkable fact that Barbados has the highest literacy rate in all of the developing world. Not just in a particular region, but in all of the developing world, Barbados has the highest literacy rate. The rest of the Caribbean has high literacy rates too. That represents the focus of the governments in subsidizing education. So primary schooling is universal, paid for by the government. Also secondary education. The only distinction here is that to get into secondary education, certain schools, the better schools, require external examination. So people who have more means, wherewithal, are usually better prepared and do better on the test and can occupy the available seats for secondary education. But the standard of living overall is higher here than in other parts of the developing world. Well, that is not to say that poverty does not exist. Poverty remains a plaguing social phenomena. 31% on average of people live at or below the poverty level. I mentioned St. Kitts Nevis before. Even though it is moving forward and ahead, it still does have a high poverty rate of about 35.5%. Now, there is a difference in income poverty and non-income poverty as it affects our discussion today with regard to disparities, health disparities. Non-income poverty has nothing to do with economic issues, but it has to do with attitudes. We find that people who are poor also tend to have feelings of low self-esteem, feelings of lack of empowerment, a lack of confidence, lack of political power influence, and these attitudes does affect their assertiveness in seeking out healthcare, even basic healthcare that may be available. It's simply not an area of priority or interest for them. They don't see healthcare as a right, but perhaps as something that people who are better off can get for themselves. And these attitudes, in fact, emphasize and exaggerate the problems. Because there is still quite a bit of rural living, this contributes also to poverty. There is a movement in some of the Caribbean islands from agrarian-based existence to urban existence. But with urbanization comes displacement. And in fact, the individuals don't bring with them the skill sets that they need to survive well in urban environments. And they don't have governments that can provide for them the social programs that might be facilitative while this transition is going on. So combine all these things, plus a decline in exports, sugar from Barbados, for example, and bananas from St. Lucia, you have a profile that explains why you have such a remarkable level of poverty. When you don't have much, what you do with what you have becomes absolutely crucially important. So, my question to you is, are the poor benefiting from expenditures for basic to tertiary levels of healthcare and education? I just told you that the government subsidizes education for everybody, and it subsidizes healthcare as well. But are the poor benefiting? The answer is, unfortunately, no. Who benefits then from subsidies to university and hospital-based curative services? The non-poor do. And the reason for this is that for tertiary care, which means hospital-based care, period, the governments, in order to recover some cost, assign user fees. And people who are poor simply don't have the resources. So they rely strictly on basic services. So that's why it's important to work with attitudes so that they access at least basic services, which are provided in clinics in areas dispersed around the island. So in remote areas, in urban areas, there are clinics that are sponsored by the ministries of health, and this represents the public health approach to basic services that they need. There was some experimentation with assigning user fees even for basic services, but that failed dismally because you're disenfranchising the already disenfranchised when you do that. So we have an example of two separate islands whose approaches have been very different in terms of how they allocate their resources. If we look at Trinidad and Tobago, Trinidad and Tobago is better off economically. You know why? You know how much you're paying for oil out there now at the gas pumps? Trinidad and Tobago is rich in oil. They sit very close to Venezuela. We know Venezuela is rich in oil. They're tapping the same natural resource. So Trinidad and Tobago really has more of a robust economy. They have more dollars to spend. But they have chosen to spend their dollars on tertiary care. They have built a beautiful tertiary center, a hospital, state-of-the-art. But for many years, much of that hospital remained closed because you need expertise, manpower, trained individual, infrastructure to open and run a state-of-the-art hospital. For every $10 that they spent, $1 was invested in basic services, and $9 was invested in tertiary care. Do you think that's going to approach managing NCCD, early diagnosis, early treatment? So the government made that decision that they would allocate primarily to tertiary care. So what happens when you do that is that people self-diagnose. They don't go to a primary care facility. They don't get diagnosed in a primary care facility, and they don't see one out there that's readily accessible to them, so they diagnose themselves and take themselves to the hospital, get care at the hospital. Where's the most expensive place you can get care? In a hospital, in an emergency room, in a hospital. On the other hand, Dominica is one of the poorest, but they have chosen to spend their money in basic services. So today, in Dominica, every single child is immunized against polio, diphtheria, tetanus, and polio, diphtheria, tetanus, and measles. So you make the decision which approach you think will have the biggest social returns. And that's what we're looking at. We talked about poverty, we talked about resource allocation. Where do you get the biggest bang for the buck? In terms of moving forward, we know that the average expenditure on education and healthcare as a percentage of gross domestic product is higher in the Caribbean. The target is that every country spend at least 6% of its gross domestic product on healthcare. Right now, St. Lucia spends about 4.3. Most of the countries are at or above the 6%. But government subsidies will not be adequate alone. The private sector needs to grow. And in so doing, will stabilize the economies of the Caribbean and create regional solidarity. Enter in the picture again CARICOM as an example of an organization that exists to promote regional integration and regional solidarity. One way in which private spending can increase is by having Caribbean health insurance, which is something that's being talked about now, where there would be private dollars invested in the Caribbean insurance industry that would allow for portability across boundaries. Just imagine that, 40 miles away, 60 miles away, just a short travel over water and you're in different jurisdictions. All of these little islands are sovereign nations. So that in order to have usefulness in exacting the best that you can get out of what you have, making as much making as much as you can to make the borders seamless would improve and increase the benefits that they can derive. So the implications are pretty much self-explanatory. If you look at what history has taught us, if you look at what theory has predicated for us, public funds should be used to support basic services. If public funds support tertiary service, recovery costs from higher income users through appropriate charges ought to be assessed. And most Caribbean countries need to improve the quality of basic services to all. The modern public health system was introduced only in the 1960s, but following that, we saw some dramatic changes. That's when infant mortality rates started to drop, and that's when infectious diseases started to disappear off the scene. So we still, though, have a way to go in terms of improving the quality of basic services. What we need is strong public health leadership, and we need more trained personnel in the areas of public health. How do you know what to do? What gives you direction? If you have surveillance data, then it can tell you where you ought to focus, how you ought to proceed to intervene. However, the fact of the matter is that CARIC, I mentioned that before, only have 21 countries subscribing to it, and not all of them are in the Caribbean, because Bermuda contributes and supports CARIC, and so CARIC collects data, surveillance data for Bermuda, but Bermuda is not part of the Caribbean. And the membership, however, is growing, but we do need to get more of the countries subscribing to CARIC. Non-communicable diseases does not mean non-transferable. In essence, we can still see increases, obviously, in incidence rates in non-communicable diseases, even though they're not being spread from person to person. But habits are taught, habits are spread, unhealthy habits. You look at television, you go on internet, you see things that contribute to unhealthy lifestyles and then are soon adapted by people who are influenced. So we need to understand that one of the important risk factors is just exposure to unhealthy lifestyles. And that occurs just in country when people move from rural areas to urban areas. That also coincides with a shift from high physical activity and low calorie consumption to high calorie consumption and low physical activity. Ministries of health lack the data that they need, and that is going to continue to impede progress until such time as that data becomes available. Chronic diseases are the cause of premature mortality, with almost half of deaths of persons under 70 and for 2 out of 3 deaths overall. So, yes, there's been sustained, steady progress in decreasing infant mortality rate. Indeed, there has. Yes, these successes have come post-colonially since the 1960s. Non-poverty income restricts access because attitudes are influential in determining behavior. Resources are needed for public health services, more trained people, more facilities, more clinics, and surveillance data remains scarce. Now, the Virgin Islands as a case study. As was mentioned earlier, I have been looking at type 2 diabetes and self-management. And so in this phase of our talk, we will look at what the profile is, the NCC profile of the U.S. Virgin Islands. We will look at cultural factors that are relevant in determining behaviors that have ultimate influence on whether or not you control or don't control your diabetes, and therefore do get or do not get the complications associated with it. And then we will interestingly compare selected incidents of NCCD between the Virgin Islands and Ohio. So what happens in the Virgin Islands mirrors the rest of the Caribbean. So we have the same problems: heart disease, cancer, stroke, diabetes, hypertension, maybe not in the same exact order, but they're all up as to the top as the 5 leading causes of death and morbidity. However, what we do have is some surveillance data that we collect through the behavioral risk factor surveillance system. And you may have been introduced to this in your classes. It started in the 1980s in the United States. It's now available in all 50 states, Puerto Rico, the Virgin Islands, and Guam. And it allows for regular annual or biannual collection of data on a number of conditions, but it looks at behaviors that affect your actions. So you have various modules that you can select to utilize as you survey your population randomly. In the Virgin Islands, we use the diabetes module, hypertension module, and we're really looking for personal health behaviors that are responsible for the premature morbidity and mortality that we see, and using this data then to be wise and prudent about what intervention programs we think we should sponsor. The chronic disease care model is used for the study, but it's also in fact relevant to the whole talk, because we've talked about access and utilization issues, healthcare delivery issues, and now we're going to look at self-management issue. Where is your responsibility as an individual to take care of yourself? So it's a mixed method study. It had qualitative and quantitative data. The quantitative data was descriptive and correlational, basically looking at a number of variables associated with A1C, which you know is glycosylated hemoglobin, and would tell you whether or not the diabetic condition is being controlled or not. The higher the number, the less control. The lower the number, the more control. But we will not spend time on that, because I want to talk about the qualitative data that reveals something about the culture. So there were 53 people who were interviewed on all 3 islands, St. Thomas, St. John, and St. Croix, in-depth interviews. And a thematic coding of the interview data was done by Dr. Nunez, who is very familiar with qualitative research. The aim was to characterize the self-management experience of patients with diabetes in the USVI. There were 4 themes that were extracted. I'm only going to talk about the first 2 because they have the most bearing on our conversation this afternoon. We're going to look at themes that talk about similar challenges that people face when they try to be become effective self-managers? And what are the attitudes and behaviors that are largely shaped by cultural context? Interestingly enough, though not a focus at the moment, we also saw that individuals did not see healthcare providers as giving them guidance about their diseases. They saw them primarily as pharmacy. That is, you go to the doctor to get a prescription. That's why you go. You go to the nurse, she takes you to the doctor, you get a prescription, you go home. They didn't see us as really being there to guide them in what to do. Now, this may not be the case in reality, but perception means so very much. So patient reactions also were overwhelming in terms of the fear that they feel when they think about what could happen to them if they don't control their diabetes. So there was a wide range of feelings going from fear to resilience to denial. So those were the 4 themes. But looking at the first 2, things that they thought interfered that were challenges for them is stigma, family and work demands, and limited access to healthy food options and exercise. Now, stigma. Bear in mind that Caribbean culture does have as its feature an element of secretiveness. In general, not the stereotype, but Caribbean people don't usually engage in conversation and share personal information, not very readily. They tend to be secretive. Here is what one of the respondents said. I think this needs to be more out in the open because you can have diabetes and control it and do everything that everybody else does, but it's so secretive. Everyone will treat you like you're dying. There's a stigma attached, yes, to being diabetic or having to take medicine for it. So even though she's talking as though she'd like to say something, she's secretive. She's not talking about it. And she may be projecting that there is a stigma, but the bottom line is that she herself does not talk about the fact that she has diabetes. Here is another quote. This has to do with the family and work demands. The job itself is a problem. There is nowhere for you to eat, and I am on a shift, and you can't bring any food in with you. A lot of us is diabetic, and it seems like they don't get it. I even let my supervisor know I have diabetes, but they still expect me to work 12 hours straight. Don't eat, don't use the bathroom. So this was another theme, that there's not enough support, either sympathetically or in real ways, to facilitate people taking care of themselves. Limited access to healthy food options. Making the good food choices is hard. They're simply not available in stores. Well, sometimes. Now they tell me blueberries is good, I can eat that, but when you find it, it's $5 a bag, a little bag or so. So costs, I'm fortunate I had blueberries for breakfast. But in fact, fresh produce is very expensive in the Caribbean. Looking at the second theme, which has to do with self-management behaviors shaped largely by our culture. Bush or herbs, used freely, used as a matter of normal course. Self-adjustment of medication, dosing, and importance of maintaining local diet. Complementary alternative medicine practice use. My neighbor is a diabetic too. Sometimes she buys Bush and gives me some. I don't know the name of it, but it's supposed to help with sugar, so I use it. I'm going to go to the next one and then I'll show you some correlation between the two. Here is somebody else talking about self-adjustment. Well, the doctor told me to take the insulin 2 times, but my mother tell me, I want to know if this is right. He tell me to take 25 units in the morning and 25 in the night, but she says it's too much and just gives me 15 at night, so that's what I do. Now, let's go back. There is something common in both of these, and it's something that I term intergenerational indoctrination. We, you and I, as health workers, have a hard way to toe when we face Caribbean clients who feel that their mothers know better than us because they've lived through it, they know what works, they know what doesn't work. The neighbor who hears from another friend can tell you what works and what doesn't work, and their word has more value than yours. Intergenerational indoctrination. It can work against you. So here is someone simply adjusting it. And by the way, her mother's a diabetic too. So her mother says, well, I know what works for me, so I know what can work for you. And this does not find the resistance that you would think it would find. So they may see the doctor, but they go home and they do what others in their family, who they regard and respect, tell them to do. Here's a 69-year-old female who says, I take liberty every day. Right now, I have 3 plantains, 5 or 6 tanyas, sweet potatoes. I plan to take a pigtail and cornmeal dumplings and make a big pot of pea soup. You know the attitude I take. I live 70 years eating the same thing. What? Now it's going to kill me? So the relevance of people and what they eat and the importance they attach to it cannot be minimized. So yeah, what's an intervention? We can make the same pea soup healthier. But you don't tell her she cannot have pea soup. So by example here, I'm trying to show you how culture can work against us if we don't understand it and if we don't use it beneficially to help our clients. So we see it does have a unique influence on self-management. We see the participants describe similar challenges, and we know what they were. So implications: tailored interventions to address the unique needs of the population. We need to raise awareness, mount educational campaigns, get legislators involved so that maybe there can be as much enthusiasm about passing laws that would help require employers to give some recognition and deference to people with NCCD as we do for people with disabilities. To some extent, I think we need to be thinking in those terms and in along those avenues. And solutions can be developed within a cultural context that allows for inclusion of traditional food but respects belief. Don't try to work against culture. You'll lose every time. So let's look at us. What do we have in common, where, and how? I selected these 6 NCCDs and compared what the incidence was here in Ohio and in the Virgin Islands. Hypertension, a little higher in Ohio. Cardiovascular, about twice as much. Diabetes, in the USVI, we have a slightly higher incidence. Asthma, a little higher in Ohio. But look at the last 2. Obesity, 24.9 in the Virgin Islands, 23 in Ohio. Overweight, 32.7% and 17%. The majority of all Caribbean women are overweight, and 1/3 are obese. Now, I might be thrown out of my gender for sharing that information, but it is the truth. So the obesity statistic that we see primarily is contributed to, at least in the Caribbean, by women who are overweight. So women help people. Here is an area, women's health. It's the women who are responsible for this high statistic. So the U.S. Virgin Islands shares the same NCC burden. We are alike in many ways. The research that I've been doing reveals that there are cultural challenges to be met, but can be met, of African Caribbean diabetics. Ohio leads in cardiovascular, but the Virgin Islands leads in those who are overweight and obese. The last part now, equity. Let's look at key elements of CARICOM's response to health inequities and needs. And let's identify the framework to be used to reduce the negative impact of NCCD in the region. We're back to CARICOM. CARICOM in 2001 said health is wealth. That's an important statement. Heretofore, CARICOM's initiatives were all about trade, all about how to get richer, without thinking about the human capital and how to preserve that by keeping people healthy. They have come to realize that a strategy that focuses only on bringing money into a country is not a sound strategy. You have to have healthy people. Otherwise, one or two things will happen. They'll use up all the money in terms of trying to recover, or they wouldn't be able to enjoy the economy because their health status would in many ways disable them. So in 2001, they met in Nassau in the Bahamas, and they came out with this declaration. And they decided that they would establish a Caribbean Commission on Health and Development. And that task force came into existence in 2003 and started working vigorously on certain initiatives, one of which is to restructure primary care service and emphasize access back to basic services. And second was to tackle obesity, even if by legislation, preventing food importation, foods that are high fat and high calorie. Yes, they can do it, they're sovereign, they can do it, they will do it. In Barbados, for example, franchises, fast food franchises are simply not allowed. The only one there that I have seen is Kentucky Fried Chicken. Now, that doesn't mean fast food is not available, but the government simply said we're not going to have any fast food chains. Whether that was an economic decision or a public health decision, I don't know. But I'm just showing you that the governments have that authority. So they can restrict what food is imported if they think that it's going to mitigate against their plans to fight obesity. We need a strong public health force, and CARICOM has agreed that that is what it ought to do, and that living standard surveys and sharing of data is also very important. The aim is for at least 6% of the gross domestic product to be expended for health. And as I said earlier, most countries are at 6% or exceed 6%. Curbing migration of nurses, the last important point here. In the Caribbean, many nurses are trained, and they are well trained, but they are then drawn away to cosmopolitan areas, to North America, even to Europe. And so there's that brain drain. What they're doing with CARICOM is deciding that they would allow nurses to cross boundaries so that they can migrate to other Caribbean islands, no immigration problems. And so in doing that, they hope to keep the expertise in the region rather than have them go permanently away. So they create incentives that would allow them to stay within the region so that they could go to other islands maybe where they see benefits for them. And this is an initiative of CARICOM to begin to try to keep manpower in the region. Last year, as a follow-up to the NASA declaration, there was a Stemming Up the Tide non-communicable disease session organized by CARICOM and PAHO, focusing primarily on reducing risk factors. They decided to use their tobacco taxes to address health issues in the area. So CARICOM has declared health is wealth. It created CCHD, which is now shaping policies and initiatives to improve health inequity. And then the summit in 2007 reinforced what NASA said the NASA declaration said in 2001. So 4 things to take away. Positive indications of progress in the Caribbean, yes, we do have. Changing demographics, what's the life expectation? Right now, the average life expectancy is 69 years, which is not that bad for a developing part of the world, but there is great variation there as well, because Anguilla has a life expectation of 77, The Virgin Islands has of 78, the highest in the region, and that approximates the general life expectation here in the US. So the changing demographics have given way to NCCD. We are living longer. Resources need to go to primary care and public health, and CARICOM as an administrative organ is at the forefront in setting those initiatives. So those are the 4 major points I'd like to leave with you. And I thank you for your attention, but I also would like you to comment, ask questions. So at this point, I think that's what we'll go ahead and do. So if please, some comments, questions.
I heard a statistic just recently that 50% of the healthcare dollars in the world are spent in the United States. Yet our outcomes are not the best. What would be your reaction to that? What should we take from that?
She's just saying, Dr. Lotus is saying that she heard that 50% of the dollars in the world is spent in the U.S. Yet still, the U.S. is not, for example, up to the very top in infant mortality rate. You know, you have Scandinavian countries and the rest of that. What does that mean? Hard to say in a sentence or two, but obviously there is something about how those dollars are allocated, how healthcare is managed in this country. And we know that the private sector has a primary role, and we know that healthcare is proprietary in some arenas. So I don't know exactly what we can make or take from that, but it obviously says that we need to do something differently. If you spend a lot of money and you don't get much out of it, then obviously there must be something in how you are allocating. Just like in the Caribbean, the allocation needs to go to basic services. I don't know why it would be any different for developed countries.
I had heard recently from one of your colleagues I think she's in Tobago or Jamaica, that you're seeing a reverse migration in some of the islands, particularly like Barbados, of people who migrated out for work, now retiring and migrating back. And any thoughts about the impact? They'll be bringing chronic illness back with them potentially and risking it.
But I think overall good, because many people also, when they come back, they bring a sort of economic boost to the Caribbean island. They have worked away, they have amassed whatever assets, whatever wealth. They bring it back, and hopefully they also bring back, if they've come from countries, developed countries, they've also bring back an understanding about how to take care of their health. So if anything, they might be people that I would muster in my army to go out and tell others on the island how to go about managing. Look at me as a testimony. I've lived richly these last few years of my life because I've had health on my side. People tend to go back to their roots on retirement. And so I think we could use this in a positive way. Yes, Bahare.
I know we talked about this when Ashley and I were there, but and I wasn't aware of this for anybody else, but with the new, presidency and whatnot, how we talk about how all the issues that all the health care and whatnot, they look at the states, but it also affects the U.S. Virgin Islands, and how is that? Do they take into consideration what your needs are with the needs down there and whatnot when they come up with these plans and stuff for the health care?
Very interesting question. So basically, Bahare is saying, with a new administration, and let's say the new administration is moving towards insuring everyone, how is that going to help the U.S. Virgin Islands since we are part of the U.S.? Is that a fair interpretation of your question? Well, wait and see, hopefully positive. What's different about us is that we already have a certain measure of national health insurance, even though I wouldn't call it that, because we have one hospital subsidized by the government. No one can be turned away for care. If you don't have money, you cannot be turned away for care. So at least one can argue that we have a feature of national health insurance. Whatever the plans are in this country, though, will, I imagine, ultimately affect us because we are part of the federal profile, so to speak. Whatever the federal government does would affect us as well. But I think we have already had a certain experience that's unique to us and different from what's available in this country. Ashley.
People, I don't remember her name was when I was down there, but do you know how many people are underinsured or uninsured in St. Thomas?
There are quite a few people who are underinsured and uninsured. Most of the people who are insured through a government sponsored health insurance. But again, it truly should not affect basic services. Why some of the people who have migrated to the Virgin Islands don't come for basic services is because they're afraid that their illegal status will be revealed when they come to clinic. But it's not that they can't come. Even though they're sliding scale fees, if they can't afford to pay, they don't have to pay. So that the impact of uninsurance, while not good, is still not as severe as it is in this economy. Any other comments, questions? Then it's been my pleasure. I thank you very much for your attention.